2, 1. Sir, we can start now.
Okay.
Yeah.
So, I welcome you all. I'm Dr. Tossi. I welcome you all on behalf of WeAreSpine and and OrthoTV for again this one great session on tricky situation in spine surgery. We'll directly start with Dr. Sheetal's presentation. So I hand over to Dr. Sheetal.
Yeah. Thank you, Tausif. Thank you. This the heading that I was given was to see if any other conditions mimicking spine. So I have slightly taken the liberty to expand the topic and get on to tricky situations in spine surgery, which we face in our practice day in, day out. So can we have the next slide, Tausif?
Yeah.
Yeah. So success in spine surgery, it involves a lot of careful patient selection and counseling regarding the expectation from surgery. So success in spine surgery regarding careful patient selection. Patient selection is going to be based upon your history, what you're eliciting, your imaging, what you're going to be seeing, your clinical examination, and your correlation between your clinical examination and your imaging. If at the end of this whole exercise you feel that surgery is still an option, then counseling the patient regarding what is going to get better and what is not going to get better by surgery, this needs to be completely explained to the patient. Yeah. There are pathologies like avian hip, insufficiency fracture of pelvis, impacted neck femur, or an SI joint pathology, or osteoarthritis of knees, or other neurological disorders which can mimic the spine out as the culprit. But if they occur alone, that means any of these pathologies can be dealt with easily if they occur alone. But if they occur in a combination with a spine problem, then they create a challenge for the clinician. And the challenge is to analyze what is causing the present disability and which pathology amongst them needs to be addressed first. So this makes it very much challenging. Okay. So most of us see patients if there is any significant arm pain or significant leg pain, difficulty in ambulation, or any fine function dysfunction like tingling, numbness, difficulty in holding, gripping things, then these are the most common symptoms that the patients present to us with. So this overlap of symptoms and the disability due to the pathology can create a confusion. Yeah. There are two things that we keep in our mind. We see if the severity of the problem is such. If the severity of the problem is mildly compressive, moderately compressive, or significantly compressive, then it makes a whole lot of difference. If it's a non-compressive etiology, something like a TV spine only with spondylodiscitis, which we covered in our last lectures, then just a culture, starting on proper AKTs, bracing, these will take care of the problem. But if it's a moderately compressive etiology, such as a mixed picture of both the pathologies, like a diabetic patient with LCS. So LCS is not very severe. The lumbar stenosis is not very severe, but at the same time, the diabetic neuropathy part is also not very bad. So here we are going to be having both the specialties coming together, analyzing the situation, and then taking a call on how to go about it. But if it's a significantly compressive etiology, that means you see the MRI and you say that this is going to need surgery, then it's a big problem for the clinician. Other entity is the common problems that we see in our practice and the rarer ones. So as the severity as a part to distinguish is one component, the other component is the commonness of the etiology. So combinations like lumbar canal stenosis and diabetic neuropathy, or tandem stenosis, or osteoarthritis with lumbar canal stenosis, or Parkinson's with lumbar canal stenosis, these combinations are common, which we'll see much more in our clinical practice. But the prognosis needs to be explained, because here there is a chance that you're going to be needing surgery, and that needs to be explained to the patient as to what's going to get better, what's not going to get better. Other end of the spectrum rise the non-surgical etiologies, but they present to us in our clinics, like multiple sclerosis, or severe vitamin degeneration, vitamin B12 deficiencies, or osteostomas, presentations in which sometimes are very rare, but they need to be kept in our back of our mind when we are examining and coming to a diagnosis. Yeah. So we rely a lot on inputs from our neurologists, our orthopedic surgeons, and radiologists to give us insights about what we are dealing. Neurologists, as a policy, we have all our patients pre-surgery seen by neurologists. Orthopedic surgeons, they're going to be a big help for us if there's a combination of a lumbar canal stenosis with severe osteoarthritis of knees, or if there's a combination of neck pain with pain going down into the arm, if it is a shoulder plus arm pain etiology. Radiologists, we discuss when we are in trouble as to what are we looking at as the diagnosis. And I feel the most neglected of them is the electrodiagnostic studies, which we completely rely on the neurologist to coordinate with us for. Just a brief sort of an outline as to how the how the electrodiagnostic studies can help us in different etiologies. I made a list of few things that we can keep in our minds. So electrodiagnostic studies are going to be useful to document radiculopathy, whether there is going to be a radiculopathy or not going to be a radiculopathy. If there is a radiculopathy, then it will be picked up by the EMG nerve conduction studies. If the problem is small, but the significant symptoms are there, then we can document that this small problem is giving rise to this kind of a problem. But if the MRI is clean and the symptoms are very much like nerve symptom, it is equally important to document that there is no compressive etiology in which the MRI, which show that there is no compression and the nerve conduction studies will come out normal. Spinal stenosis, radiculopathy at multiple levels, or to differentiate between spinal stenosis from peripheral neuropathy, it is important in this background. SI joint, the EMG nerve conduction studies are going to be normal, and a SI joint block is going to be diagnostic in such a case. Yeah. Plexopathies, if there's
Sir,
yeah, tell me please.
Sir, how lumbar canal stenosis at multiple levels is differentiated from peripheral polyneuropathy by this electrodiagnostic?
No, it will not be. It will be the reading will be a mixed picture. It will
Yes,
be a
sir.
radiculopathy plus a polyneuropathy. The readings will come in that, but it will help to differentiate that it is a multiple level etiology. Not differentiate these between these two, but a background of stenosis at multiple levels on a background of neuropathy. That's what I meant.
Sir, can you come again? I still couldn't get it, sir.
No, what I mean is that the multiple level etiology can be coming through as radiculopathies at multiple levels. It will also show that it is going to be showing neuropathy. Not exactly differentiate, but it is going to put both the points in front of you. That's what I mean.
Okay.
So if Dr. Nitin, if I come in, sir, hi,
Yeah.
good evening.
Yeah, sir.
Hello, sir. Hello, sir.
So basically it will be able to tell you a prognostication. At the
Right.
end of the day, your patient wants some treatment and some solution for the problem. And if you have a mixed picture, you will have to tell him that there's a problem which is going to remain even if I try to treat your LCS.
Right, right. Thank you,
Sir,
sir.
please carry on, sir.
Yeah. So plexopathies, here sensory and motor deficits that are not matched to a single root level will suggest it's a plexopathy. Carpal tunnel syndrome, which you see very commonly in our patients, and sometimes can be confused with initial presentation of cervical spondylotic myelopathy. These studies will be very helpful in this diagnosis with carpal tunnel syndromes. Yeah, next please. Guillain-Barré syndrome, another common thing that we see in our clinical practice. But you have to ask for F-wave studies in this case. This is what something I even learned when I was going through the preparation for these studies. Piriformis syndrome, it's a muscle-induced sciatic neuropathy kind of a situation where we have similar symptoms coming down into the leg, pain going along like a sciatic nerve pain, tingling, numbness, and everything else. Here, the studies are generally normal, but here there is something known as edge reflex, which is completely affected. So you have to ask specifically when you're looking at these etiologies. Next, please.
Sir, what is what is the
ask in the sense you
F-wave
have to keep it in mind. Suppose you're seeing an MRI,
what is the F-wave studies you have described in Guillain-Barré syndrome? And what is
So
the
I will
importance?
not-
How it is found?
No, so I will not be able to tell the detail of the F-wave part, but this is what you have to ask for when you are coordinating with your neurologist and your electrophysiological department. So this is what even I learned when I prepared the presentation. So I'm just coming through with information. So these are the things you need to keep in mind.
So may I come in for F wave and H reflex?
Yeah,
Come
yes.
in, Tosif.
Yeah. So if you plot the EMG graph on a straight line, it will give a couple of waveforms. So F wave is a fasciculation wave, for which F stands for. So, especially in Guillain-Barré syndrome, this is a very diagnostic EMG study or EMG diagnostic feature of Guillain-Barré syndrome, which stands for fasciculation wave. And the H reflex is especially it is seen, if I'm not wrong, in NCV studies where there is inversion of the wave, which they call it as H reflex.
Yes, it is seen in EMG, sir. Yeah, the NCV studies. Yeah.
Yeah.
Thank you.
So basically, these terminologies will be put up on a EMG NCV report, and I
Right.
think you should understand it. H is Hoffman's reflex, and it's a different topic altogether. I think everybody should be aware of how to read the EMG NCV report, maybe not the waveforms, but at least the report.
Yeah. Dr. Tosef.
Yeah.
Sir, I was wondering when you say about this F wave be seen in Guillain-Barré, sir, I was wondering this would be seen in any upper motor neuron disease. Sir, am I correct or?
So, if we consider Guillain-Barré, it is not upper motor per se. If you need to understand that EMG and NCV, it is altogether, as Dr. Harshal said, it is altogether different topic, and you need to study the nerve muscle junction and muscle itself.
Right.
And then you can understand the exact pathophysiology of origin of these waves. So
right.
It is altogether different topic per se.
Right.
But to explain in short, or you can directly discuss it with your neurologist or neurophysiologist, and they will let you know basically what it is exactly.
And question to Dr. Moite is, sir, when we think about these mimicking conditions, say when we are thinking about this Guillain-Barré,
yes.
so I was thinking about, patient is having a primary tumor in GI or in chest, and then they are having some sort of a paraneoplastic syndrome which is presenting as a Guillain-Barré.
No, the usual presentation here is a sudden onset weakness in both the lower limbs, which is usually a symmetrical weakness.
Yeah.
And it is with sensory involvement. And it is on examination, they have hyporeflexic as a hyporeflex or areflexic jerks. So that's the clinical usual presentation.
But sir, there is motor palsy also, right? Motor palsy.
Yes. It is both lower limbs. Usually it is symmetrical and hypotonic kind of situation.
Yeah. So sir, I was wondering when it is this an ascending kind of a paralysis. So could there be conditions within Guillain-Barré that वो lower limb तक तो आया, but लेकिन diaphragm को कभी impact नहीं किया और ऊपर नहीं गया, Guillain-Barré नीचे रह गया,
it is possible.
ऐसा भी हो सकता है.
Yeah, it is possible.
Okay. Thank you, sir. Thank you, sir.
So Nitin,
yes, sir.
If you read the Guillain-Barré or GBS per se, there are different variant of GBS.
Yeah, Miller-Fisher and these kind of things.
Yeah. So the involvement of diaphragm in GBS, it is termed as severe form of GBS,
right,
where recovery is the dicey one.
Right.
So, right. So the scoring system with GBS, basically with diaphragmatic involvement, it goes to the higher level, and the recovery is dicey one, as I said. And basically, there can be different variant of GBS and
sir.
different differentials for GBS. Paraneoplastic syndrome is one of them.
Right.
Yeah.
Yeah. Thank you, boss.
Yeah.
Right.
Sir, I want to ask one question. How to with the GB syndrome? How to differentiate it with the other spine mimic condition, or in other words, which are the other spine mimic condition in which we can look for the symptoms just like GB syndrome?
So I've got some few cases following this. So let's see if you have at the end of this, if you have any more suggestions. So I'll come to the cases that I'm going to show next. So if you can just hang on for a couple of slides more, then we'll start the case presentations part. Hello.
Yeah.
Okay, fine. So the important scenarios that we see, as we discussed earlier, the commonness of the situation and the things that you can keep at the back of your mind. So tandem stenosis, what Harshal had covered very extensively, is an important clinical scenario. Now, lumbar canal stenosis with osteoarthritis of the knees, or with diabetic neuropathy, or with Parkinson's, or with hips. These are different situations that we are seeing nowadays, especially the avian hips post-COVID that we are seeing. But imagine the LCS symptomatology that we all have gone through, and when Harsha took that lecture for us for lumbar canal stenosis. So if it is OA knee as a culprit, then I'm going to see LCS symptoms plus knee pains, more in the anterior part of the knee swellings, restricted knee movements. On examination, patient will wince when you are trying to bend the knees, and this kind of a whole symptomatology will need to be coordinated with whether these symptoms are so or no. Important other clinical scenarios that you are going to be seeing less commonly, but is.
Hello.
Yes, 1 second.
Yeah.
No problem. There's some mistake. Yeah. Cervical radiculopathy with the periarthritis shoulder. This is also sometimes a common etiology in which we are saying the patient points out to the shoulder as a main painful area, and the pain usually is going into the upper arm. Restricted mobility is there. He is not able to abduct and not able to internally rotate. So that initially what some patients were initially thinking of neck pain going into the arm is essentially a shoulder problem. Sudden onset of severe back pain. We have got 2 or 3 beautiful cases lined up for this. If there's a sudden onset of severe back pain, what to think of. And a small couple of cases on osteostomas. Very clinically relevant and very rare kind of presentations also. Okay, next.
So what is CSM?
Sorry?
Carpal tunnel syndrome versus CSM. What is the
CSM is cervical spondylotic myelopathic presentations, in which sometimes there is tingling, numbness of the hands and everything. So that can sometimes be confused with carpal tunnel syndrome. So that's a symptomatology overlap. And other less common situations like a severe B12 deficiency giving rise to combined degeneration of cord, or a hypothalamic periodic paralysis, acute onset that we discussed just now, or even multiple sclerosis. So we'll go through different case studies here now. So 52-year-old female with sudden onset of pain in the left leg, below knee type on the posterior aspect, nothing at all on the other leg. Pain is increasing. It is with standing and walking, not even able to walk or sit on through the toilet, giving severe pain. Not relieved much by analgesics. Medical issues, hypothyroid. This was done as a phone consultation, and listening to the symptoms not getting better over the duration of around 5 to 7 days, we asked the patient to go ahead with an MRI. So this is the picture on an MRI. As a policy, we ask for whole spine screening, but in this case, this shot has only the thoracic and the lumbar, but rest be assured there's nothing in the cervical because I've seen the images. But it shows a significant stenosis here, lower lumbar L1, 2, 2, 3, 3, 4, 4, 5. 5 is sacralized with bilateral neural foramen narrowing and probably a disc extrusion. At the same time, the more important part is the dorsal spine also that we are seeing. So there is a compression in the dorsal spine also. The cord is showing myelomalacic spots. So there is a significant compression here. Can we have next one?
Yeah.
So how do we go about in this? As we had seen with Dr. Harshal's presentation, tandem is sometimes a very confusing etiology. So how should we go about the plan? Presently, patient is resting it out because seeing this left pain and everything else, I have told the patient to take bed rest, and she's going to revert after 2 weeks. So how should we plan? Do we need any other investigations in addition to this? And how do we do about it? Do we just take a consensus of the house? Do we tackle only the lumbar or lumbar plus dorsal? So we can have inputs. Any other investigations you all want? Seeing the MRI picture?
Nitin, can you take it?
Yes, sir. Yes, sir.
Yeah.
Sir, I was thinking that that this MR is showing this picture and patient is hypothyroid. So is hypothyroid controlled or not? Because it can also have implications on some nerve issues. So this is one thing that I was thinking. Second thing, when it comes to these leg pains, so the thoracic disc which is present there, it is not contiguous with the leg pain symptom which is present.
Totally.
So in that context, it seems that the lumbar feature is there, and as you mentioned, sir, that it can be documented. It can be documented by getting an NCV done कि वो जो लेग पेन वाला जो डिजीज है वो लंबर से अराइज कर रहा है लेकिन थोरेसिक से नहीं. बट लेकिन जो डिजीज की सर जो लंबर स्पाइन की जो सिवियरिटी है, सॉरी सर, स्पाइन में जो सिवियरिटी है वो ज्यादा खराब डिजीज डॉर्सल स्पाइन पे है. तो सर इस डॉर्सल स्पाइन को तो कुछ करना चाहिए सर.
Yeah, so that's why I put up the question. So I completely agree that the dorsal spine is significantly affected. The reason is we have not seen the patient. So that's why the dilemma is there in our case. We have not seen the patient, but I completely agree that the dorsal cord is significantly compressed. The calcifications that we see is the more worrying part for me because I feel it's a ligamental calcification, flavum calcification. If this is seen somewhere like this in a dorsal area, we generally ask for CT scan in addition. So just to document the ligament calcifications and it may be an PLL calcification also, and it may be ligamentum flavum calcification also. The same thing can be expected in the lumbar spine also. Not that it will make a change in approach as to whether we are going to do decompression or not. It looks highly likely that the decompression may be necessary in this case. But if we see calcifications in such cases, then at least we are mentally ready to keep things like probably a burr to thin off the bone part, or be ready for situations in which we're going to be having a stuck ligamentum to the dura and maybe having even dural tears in such situations, rather than panicking after having opening up the levels of surgery. So I feel CT scan will tell us these things. Some may say that CT scan is showing the same, but are you going to change your plan? So plan may not change, but it will help with the readiness of the surgeon to keep an open mind about having to tackle about these situations. Other than that, I feel SSCP may be important because you're looking at cord involvement here. So a cord involvement showing delayed SSCPs is going to be something that you may expect as a finding in the electrodiagnostic studies. And obviously in such situations, you're going to have a neurological input also.
सर ये जो कैल्सिफिकेशन है सर ये कैल्सिफिकेशन सर डॉर्सल के अलावा एक लेवल के अलावा कहीं और भी पाई गई सर?
Actually, the one at the highest one probably may not be seen in this case. There is one at D4, D5 level also, which is just impinging on.
Okay.
That is one, and these two levels. So again, the decompression levels and where to go, all that will become very important in planning the surgery.
So is there any correlation between the hypothyroid state and this or any other situation which will lead to multiple canal stenosis like this?
I'm not aware of this, but
Etiology?
I generally keep that as an we do a thyroid studies because it is important for anesthetists for extubation times. So that's the correlation I find here. But regards there is so much of compression there, so I would not be much worried on other etiologies. There's so much of compression to explain the leg plane, so I
सर
would
सर
not be worried.
सर ये जो होता है ना सर हाइपरकैल्सीमिया
Yeah.
hypercalcemia at times leads to heterotopic calcifications like calcinosis. So that
Yes,
could be one thing अगर कैल्शियम लेवल बढ़ा हो सीरम का तो
could be.
हाँ
Point
सर
taken.
जी सर
Okay, yeah. Next one.
Sir, one question in the chat box.
Yeah.
The guy want to ask, could it be dish?
It could be, yes. It could be. But the only thing is, here what we presented the case with is along with the intention of showing that the problem is at both levels, and we need to probably consider both the levels of decompression. But it could be. Completely agree with that.
सर लेकिन सर जो डिश के अंदर में जो लीजन आता है सर वो सर वर्टिब्रल एंड प्लेट के नियर पे आता है
No, you're
बॉडी
looking
के
at
कहीं बीच में नहीं आता है
No, what I mean to say, I'm not saying like a fracture kind of a situation. I'm saying like
अच्छा
a PLL calcification.
अच्छा
That I'm trying to say. I'm not saying like a end plate through fracture. No.
नहीं सर मैं कह रहा हूँ तो सर ये डिश नहीं हो सकता ना
No, with diffuse interstitial skeletal hyperostosis can sometimes present with this kind of a picture. That's what I'm trying to say.
Okay.
We go next.
Yeah.
So another case in which a 75-year-old male, hypertensive.
सर पिछले केस का कंक्लूजन क्या निकला सर
So conclusion, I am saying that if I am to make a decision, I would involve a neurophysician, and I would be keen to offer surgeries at both the levels, keeping in mind that I may find a problem situation higher up, in which I will be needed to be ready for CSF leaks and dural tears, and will need to keep a burr or something like that where I can minimize the bone attachment to the dura. So generally, when we do a laminectomy in such situations, we don't do the usual putting the rounger in and pulling off. We try to do it from the gutters, from the lateral sides, and we try to take off bone as we approach medially. If there is something stuck to the dura medially, we try to burr it off and keep it as minimum as possible.
Thank you, sir.
So one thing on the dish, there is a Resnick criteria for to call it as an dish on X-rays and MRIs. There are three criteria basically. It says there should be candle dripping appearance on the anterolateral aspect on at least 4 contiguous vertebra. Number one. Number two is there should be relative preservation of intervertebral disc space. And number three, there should be absence of apophyseal joint bony ankylosis and sacroiliac joint erosion.
Yeah.
Just to clarify on dish.
Thank you, sir.
Thanks, Tausif, for that. Thanks a lot for that.
Thanks, sir.
Yeah.
So we go on to the next one. 75-year-old male, hypertensive, and both lower limb weakness, grade 1/5 in the left leg and grade 2/5 in the right leg, with early onset bladder. Since last she presented in the casualty, so we got a call from the casualty that so and so patient is coming with this kind of a neural.
Sir, your voice is not coming.
Sheetal sir?
Better now?
Yeah.
Yeah, so they said it is probably the MRI report is saying it is more in favor of a METS. So looking at hearing that it's a male who is come in and METS as the reason, then we asked for PSA at the same call itself. The next day when we went to see the PSA levels, we came to be high in high 80s, and this is what we saw the scans as. So the scan here shows the D3 level collapse vertebrae with cord compression. At the same time, the cervical doesn't seem to be very good also. So again, we discuss here as to how do we go about it. So
Can Shashank is here?
Yes, I'm here.
Yeah. Shashank, can you take this?
Yes. So as we see on the sagittal section that D3 vertebrae is quite collapsed with cord changes, and cervical C4, C5, C6 level disc space indenting the cord. There is some cord changes at that level as well in cervical region, and multiple dorsal vertebral bodies showing changes in the vertebral body. So
True.
I would rather like to go for neurological assessment as what is the neurological status of the patient. Then post neurological clinical neurological status, I would looking at the weakness. Yeah, sir. Just confirming with all those things. I would like to go for a PET scan,
True.
and yeah, that's the thing. And I would love to see the cervical screening as well, sir.
Yeah.
So like you came to know that PSA is high, basically, Shashank.
Yes.
It is greater than 10. It is like almost 8 times the normal values.
Yeah, normal value. Yeah.
Yeah. So you almost like nailed the primary. Still, you want to go for the PET scan and everything?
Yeah, I would rather because before PET scan, I would if you ask me personally, ultrasound abdomen with pelvis will also be one of the thing I would like to.
Okay. And anything else you want to do?
No, I don't think so.
Because he's paraparetic, so we will go on to what we did, and here we did a decompression of the cervical part also, and a posterior instrumentation with loop rectangle, Hartshell wire, Hartshell and sublaminar wires.
Okay.
Agreed that the system is showing. Agreed that the spine is showing significantly studded spine. There are changes in the retroperitoneal nodes also, with probably sacral lesion pickup also. Biopsy, as we said, shows the prosthetic CA. The patient was put on hormonal treatment and recovered a grade in the next 2 to 2.5 weeks post-op.
सर
Excuse me?
Yeah.
सर ये जो PSA 83 है सर, I think it doesn't tell anything, sir. Sir, because sir, PSA can be raised in a urinary tract infection. Sir, it can raise anywhere. Sir, until
But I don't think so. It will go on to this levels.
So
It will
may
not go
I
on to
come
this
in?
level.
May I come
Yeah,
in?
Tausif,
Yeah.
come.
sir.
So normal value of adult PSA is anywhere between 1 and 5.
Yes, sir.
In benign prostatic hypertrophy, it goes up to 10, not more than 10.
Not more than 10, yeah.
And if it is more than 10, it is like up to the range of 30 to 40. It is suggestive of prostatic carcinoma. If it is beyond 40, it is diagnostic of prostatic carcinoma. PSA is a carcinogenic marker. It is not any this thing. So it is very specific to prostate. And in routine conditions, though it is rare, it never crosses the value of 10.
Perfect, Tausif. They have done immunohistochemistry studies also at Hinduja, and the patient is on treatment further there. The further follow-up is necessary. We go on to the next one.
Any advantage of removal of testicles with these procedures also? I have heard of removal of testicle is also.
Orchidectomy is a treatment suggested for chemo-resistant type of prostatic carcinomas. So it is altogether oncologist and oncophysician's decision, basically. But
Very true.
yes, it is in the armamentarium of the onco surgeons as a one of the tool, basically.
Yeah. So orchidectomy is a decision completely decided by the by the medical onco team. So orchidectomy is what they said no, and they were in favor of a hormonal treatment. Chemo, they are not very sure just now, at least. The relatives and everything else, they're taking a call on it still.
Excuse me.
Yep.
Yeah.
Dr. Tosif, I just wanted to ask, like, you were asking for some steps I was missing in the diagnosis part while you asked me the question. I just wanted to know what you were planning, like what thoughts you had in your mind. Because
So
age, yes, absolutely, the age and the PSA level is most prominent criteria to rule out CA prostate.
I just want to ask you why like PET. My question was why PET. So my take on PET is not to find primary. My take on PET is like where all it has metastasized.
Just to rule out metastasis. So
Yes. So you have nailed the primary, but you need to find out where all the tumor has metastatized, and that's why PET is necessary.
Okay.
Yeah.
Thank you.
We had a PET done here also. PSMS studies were done here also. So I probably have not put it up in this presentation.
Yeah.
You can go on to the next one, Tosif, please.
Yeah.
So next case, a middle-aged man with a history of clumsiness in walking, weakness feeling, needing support to walk, persistent paresthesias, and that's been going on for the last few months. No medical risk factors. On examination, an unsteady gait and aporeflexic jerks. Other than that, basically is a walker, but needing support to walk. So yeah, we asked for an MRI here. I'm sorry for this because I had to put up a slide from the net because the patient could not send me over the MRIs here still. So this is what we had seen because it was already seen by a neurologist before he came to us. But this is what the MRI had shown. And because it's an interesting etiology, I thought I should put it up here because the presentation is very much like a neurological problem. So essentially B12 deficiencies has a presentation of range of symptoms. It can be from breathlessness, tiredness, fatigue, you name it and it can be there. It can be with imbalance and cognitive disorientation, walking difficulty. All these things are seen in B12 deficiencies. But the MRI picture is more in favor of a posterior column edema that we can see in a long segment there. So this kind of presentation with posterior column edema is very much classically seen in B12 deficiencies. Next one, please.
Yes, sir.
So I'll just, I think so I must have, done a brief workup on B12. So it is seen deficient in guys who are having dietary deficiency. That means all the vegans and the vegetarian people are more prone for this. Gastritis and Crohn's and celiac diseases have absorption issues. Gastric bypass surgeries or alcohol abuse patients, they are also having problems of B12 deficiency. And as we discussed, the symptoms are nearly what we illustrated just now, and severe cases can also have psychological issues. Deficiency, I think so the cutoff here is 150 and below, in which it can be taken as severe deficiencies. I have not seen more. I've just seen couple of B12 deficiencies presenting with such severe symptomatology. I'm not sure if everyone else can contribute to this clinical scenario, but till now I had not seen, and within a span of 2 weeks, I saw last year 2 patients of follow-up with B12 deficiencies, with very and these deficiencies and these symptoms got better with just replacement of B12 deficiencies.
Sir.
Yes,
sir,
yes, please.
How this subacute combined degeneration called? How does it present, sir? Clinically,
So that's
what it
what I
looks
said.
like?
So this is what I came to know that this is how they usually present. They usually present with these kind of symptoms of numbness, heaviness, significant paresthesias, walking difficulties, imbalance, cognitive disorders in which there is balance issues. These are the whole things that they can be sometimes very severe and cause you may be bedridden because of this. But I think so the pickup from the neurologist was very important for us to document that such and such thing was there, and the patient completely recovered with this. I think so we'll need inputs from the neuro people rather than I saying something which I'm not sure of.
नहीं सर, मैं वंडर कर रहा था सर, वो सर कि जैसे स्पाइन में डिजेनरेशन हुई है तो कोई अपर मोटर न्यूरॉन साइन, लोअर मोटर, मतलब ऐसा कुछ आने लगेगा क्या? मतलब स्पाइन विल स्टार्ट टू बिहेव ऑकवर्ड.
So may I come in?
Yes sir,
Tausif
yes sir.
comes in.
Yeah. So the subacute combined degeneration is very common in cases of pernicious anemia, where there is degeneration of dorsal column. Basically, it causes myelin degeneration per se, and it present as progressive numbness and weakness. Usually there is change in mental state. Sometimes there could be spastic type of paralysis or paralysis, and usually pressure, vibration, and touch sensation are diminished. Most of the time, the Romberg sign is positive and plantars are extensors, and it is absolutely reversible with vitamin B12 therapy if it has not gone too much long.
So I'll just butt in here.
Yeah.
There are two things which comes to mind when there's a subacute combined degeneration, and whenever we have a myelopathic type of a feature, and when it is not fitting or whenever we have a myelopathy, we try to have the extent of the disease. So what is the kind of a vertical extent, what is the horizontal extent, and everything when we do a clinical examination. When we have a SACD, it has a focal, it doesn't have a focal extent. You cannot actually determine the level. It has a diffuse kind of a combined degeneration. So you have mix and match of a symptoms. And when it is not fitting in any type of a pathology, neurophysician is the one who diagnoses it predominantly.
Okay, thanks Harshal for your input.
Sir,
So
I couldn't understand the last slide of MRI for diagnosis of vitamin B12 deficiency. Is it the diagnostic picture? It is the book picture like that, so that we can conclude that is it true or not? Vitamin B12.
This is a fairly classical picture. They say posterior column involvement, long segment, non-compressive.
Yeah, predominantly involvement of a dorsal tracts and maybe lateral spinothalamic tracts. Very commonly. Yeah.
Thank you, sir.
Tausif, next one, please. Thanks. Yeah, another interesting case, 23-year-old female, young lady. Yeah.
I raised my hand before. This is related to this B12 deficiency only. What is the practical symptoms you have seen in the worst case scenario happening with the B12 deficiency with all this mimicking the spinal injury patient or spinal problems?
What is the practical? Sorry?
Worst case scenario you have seen, like symptoms appearing in a patient.
I think so difficult for me to answer that. This is only 2 cases that I have seen till now in whatever practicing. So it's a rarity for us. I think so the most of the chunk must be going to the neurologists. I think
neurophysicians. So. Yeah.
Oh, okay.
So 23-year-old female with sudden onset weakness in lower limbs, but a walker, tingling numbness, imbalance in both the lower limbs, occasional tingling numbness in hands, but basically someone who came walking to the clinic. They had done an MRI before meeting me, and the MRI showed a mild disc and everything else, narrowing of foramen. There was no whole spine screening done. So I examined and I said that this is not matching somewhere. You get a whole spine screening done. The whole spine screening showed something else. I asked them to go and see a neurologist. So the neurologist, we got a new MRI done of the cervical spine. And this is what the new MRI showed. So just to describe the MRI for us, for everyone's convenience, it is showing plaques in the area of the cervical cord behind C2, behind C3, behind C5 to C6. There is a large plaque. There is a thoracolumbar junction, small plaque there also at the thoracolumbar junction. So essentially, we saw that it is a non-compressive etiology. There are plaques, multiple plaques in the cervical cord. So the neurologist had asked for an brain MRI also in addition to this after seeing this. And we got a report of the whole on the next slide, please. These are the cross sections of the same one. So we see plaques in which just behind the C2, the C2, 3 level, the white dots that we see. So inside the cord. So those are the plaques. Some of them are very well circumscribed. Some of them are not very circumscribed. So this patchy kind of infiltration and patchy plaques with different uptakes of the gadolinium. This is classical of MS, multiple sclerosis. In this case, there was a sparing of the optic nerve. So someone who has come into the clinic walking and not even someone had told that the issue is in the lumbar spine, which is completely now off the whole context. They've gone for screening picked up something else. As for a neuro opinion, the brain scan has shown all this. So the brain also has shown lesions in the scan. They've shown some 6 or 7 well demonstrated plaques along with these plaques in the cervical cord. So this is quite classical of multiple sclerosis. So this clinical picture of multiple sclerosis and B12 overlaps to a great extent. Tiredness, feeling weak, lethargic feeling, numbness, heaviness, tingling, imbalance. All these symptoms are to a great extent matching in both of them.
सर
But if we try, yeah, please.
सर मैं कह रहा हूँ सर अगर चाहे B12 डेफिशिएंसी हो या मल्टीपल स्क्लेरोसिस हो, ये दोनों मरीजों को कभी भी पेन नहीं होता है सर. करेक्ट सर, ये पेन लेके नहीं आते हैं.
Exactly. This is more in favor of numb. That's why the cord, if it is involved, na, it is more numbness, heaviness, proprioception issues, imbalance issues. These are the complaints that they come to with. Root is the one which gives you pain. Root if it's involved. Cord will give you all these negative symptoms.
Thank you, sir.
So if you try to analyze, these are the common things that you see. If you try to analyze and see how they will differ, it is very difficult, but there are subtle points. In case of B12 deficiencies, the B12 deficiency is more sort of peripheral in presentation. The B12 will be more symmetrical and the B12 will be more in the lower limbs. So this is how somewhere it will differentiate itself from multiple sclerosis. Multiple sclerosis will be presenting in a situation in which it is erratic presentations. It can be upper limb, it can be lower limb. It is going to be non-symmetrical. And there is no preponderance whether it will affect only upper limbs or only lower limbs. So that's the subtle difference that we see in presentations of both these, in addition to the common symptoms that we described.
Sir, please repeat once. Repeat, sir, repeat.
Yeah. So if it is going to be B12, B12 has a prediction for affecting only lower limbs, more lower limbs. Then it is predominantly symmetrical and it will affect more the peripheral system. Whereas the multiple sclerosis will affect more the central system. The presentation in multiple sclerosis is going to be patchy. Upper limb, lower limb, no predilection as to which side or which upper limb or lower limb is going to be involved, because it will depend upon how the cord is getting affected. So the presentation is going to be obviously different. And there's no symmetrical presentation in multiple sclerosis. And there is no upper limb more than lower limb in multiple sclerosis. I made it clear?
Thank you, sir. Thank you, sir.
Yeah. Okay, I think so. We discussed this Guillain-Barré. We can have the next one, Tausif, please. Transverse myelitis. I think so. This is also an interesting one, though I will not be able to explain other than what we have here as to But here the classical thing is there is a sudden onset of severe back pain, and there is again weakness in lower limbs and a sensory deficit plus autonomic dysfunction. So I think so. This is the only way that we can probably try and differentiate between classical presentation with transverse myelitis. The severe sudden onset back pain is a significant cause to be kept in mind. Does you have any additions on this you have?
There are some diagnostic criteria for transverse myelitis, especially acute,
Okay.
acute transverse myelitis. It is inflammation within spinal cord, which can be diagnosed by CSF either, or elevated IgG levels, or MRI with the contrast, basically.
Yeah.
They have also described something called as IgG index on the CSF basis, where they combine, like they add CSF IgG plus serum IgG, and it is multiplied by the CSF albumin and serum albumin. This is this product basically is called as IgG index. It is supposed to, I don't know exact value of it, but it's supposed to be higher in the transverse myelitis.
Okay.
And sir, there is also, sir, albuminocytological dissociation.
Okay.
So,
yeah, hearing you. Yeah.
सर मेरे को सर इसके आगे नहीं पता सर, मैंने ये वर्ड ही पढ़ा था कल, मेरे को डिटेल नहीं पता है.
No, this is news to us because we don't come so commonly to these etiologies, but I needed to bring it up for the presentation. We can have the next one, please, Tasif. Again, another scenario: 42-year-old male presented with weakness in both upper limbs and lower limbs. There is imbalance and walking difficulty since 1 week. MRI of the brain and cervical spine was asked for, and serum electrolytes was done, and serum potassium was low in this case. This is a case actually I've borrowed from Bojraj Sir's unit, because prior to this I had seen only one, but I had no data on that, and I thought it was an interesting case, so we should put it up in our discussion. So this is what the MRI showed, and 2, 3, 4, 5, at C5, 6, there is a cord indentation, and just about indenting the cord. But I feel this kind of a cord indentation would not be responsible for the gross neurology that you are seeing, and that's the reason I feel so. The unit went in to have a neurology opinion, and the neurologist asked for the serum electrolytes, and the serum potassium came through as a low serum potassium. Next one, please. So his diagnosis at the end of this was a hypokalamic periodic paralysis. So this is something I've seen only, again, 2 cases of this type. And if it is 3.5 and above, 3.5 to 5 is the normal range, 5.5 is the normal range. Anything less than 3.5 is counted low. 2.5 to 3.5 is moderate deficiency. Anything more than 2.5, lesser than 2.5 is a significant deficiency of serum potassium. So it leads to weakness, fatigue, cramps, palpitations, tingling, numbness, paresis, and polyuria. It is usually triggered by surgery, anesthesia, pregnancy, alcohol, strenuous exercises, high sugar or a high carb diet, and large meals and steroids. These are all predisposing factors for such kinds of presentation. There were some case studies I went through, and it showed that someone who was fasting for a surgery, post-surgery, he had a significant neurology in which he was not able to move his upper limbs, lower limbs, but central features are all right. There was no drop in blood pressures or respiratory issues. So they waited, and they post-surgery went in and had serum potassium levels done, and it came to be low in such cases, and that's how it was diagnosed in this patient as a case report. So I feel so these studies in which it is a rarity, it can be sort of precipitated by all these above situations that we said: strenuous exercises, high carb diet, large meals, steroids, or even anesthesia, and long fasting hours. So the treatment in mild to moderate cases is oral supplementations of potassium chloride and a potassium rich diet. But if it comes through as a severe deficiency, then it is replaced with infusions of potassium of KCl, and that needs to be done with complete medical supervision, because if you go higher up in potassium supplementation, you can land up with cardiac issues and cardiac arrhythmias, which will be another thing to handle. So usually these patients, they recover in the next 3 to 4 days. This patient, I discussed with Tausif, and Tausif updated me that this person got better in the next 5 to 7 days also, and the neurology completely recovered. So this is something which is known as hypokalemic periodic paralysis. So this is another interesting cause for this kind of presentation. We can have next one, please.
Yeah. So I can add something on.
Yes, please. Tausif is doing a literature search on that, so go ahead, Tausif.
So hypokalemic periodic paralysis is classified under the primary substance, which is called as primary periodic paralysis. These are the channelopathies, and this happens due to mutation on chromosome 17, especially the sodium channels and the calcium channels are regulated by SCN4A gene. So that is the mutation basically. The subtypes of them are: one is hypokalemic periodic paralysis, hyperkalemic periodic paralysis, and Anderson-Davis syndrome.
Okay.
Yeah. So this periodic paralysis can present as hypokalemia,
hypo or hyper,
hyperkalemia, or it can be as a juvenile variant where it is called as Anderson-Davis syndrome.
Okay, perfect.
Yeah.
Okay, next one we have if another case in 76-year-old female, back pain, persistent back pain since 6 weeks, left buttock pain, and no fall, no jerk, no radiculopathy, no claudication, so no
Sir,
compressive.
sir,
Yeah, tell me.
सर वो जो चैनलोपैथी थी सर, उसमें टेस्ट कौन सा कराना है? कौन टेस्ट होगा जिससे मतलब फाइनली पता लग जाएगा कि भाई ये हो गया? सीरम पोटेशियम लेवल इज द ओनली थिंग, और देयर इज
So
serum potassium, yeah.
So
that's it.
So there are various diagnostic criteria for these channelopathies. Okay. Usually they present with hyper or hypo type of serum electrolyte features. Other tests which are described are electrodiagnostic studies, the biopsies, and even the genetic testing. Yeah.
Right.
So this is a 76-year-old female, back pain, buttock and higher buttock, I would say, not the whole leg surely. No claudication, no radiculopathy, intact neurology, spine signs nil. So buttock pain sometimes goes in favor of a L5S1 disc or that kind of a presentation. So we had MRI done, but MRI was non-compressive. And we had a closer look at the stir images, and it showed that there was an insufficiency fracture at the S1. So this kind of a presentation also can be quite common. And now with increasing life expectancies and increasing population with osteoporosis, I think so this is something we need to keep our eyes open to. So insufficiency fractures, it can be in pelvis region also. It can be in sacral area also. Any pelvic region insufficiency fractures are also common. They cause difficulty in walking, thigh pains, and they're not able to walk. Every time they need to sit down, that kind of a presentation. So here again, limited activity and replacements with vitamin D, calcium, they will take you through. So this is an insufficiency fracture of sacrum, and patient got better with replacements and vitamin D and everything else. So I think so. This is something we need to keep our mind open to. Yeah, next one. Another interesting case: 63-year-old male, a hypertensive, and a Parkinson's patient. Difficulty in mobilization due to significant back pain. He was bedbound, literally. But on examination in bed, essentially moving lower limbs and everything, exact neurology could not be assessed. But this is someone who was not moving much because of back pain and not getting better last 4 to 6 weeks. So imaging was done. We had asked for X-rays. X-rays showed D12 level fracture there, and it was opening up on flexion extension views. There was a small amount of listhesis at L4-5, but no major mobility on L4-5 mobility on stress views. So we had MRIs done for this, and this is what the MRI showed. And so D12 fracture with cord indentation, with probably an osteonecrotic cleft at that upper end plate, but this is something which is not very well seen in this MRI. So in this case, we offered him surgery, and his back pain issues became much better at the listhetic level at 4-5. I wanted to not go on to the lower levels for fixations, because then it would have become a very large extent of fixation. May have even needed to go to sacrum, which I wanted to avoid in Parkinson's patient with osteoporosis and everything else. So longer surgeries in such patients can have a issue or a high failure rate. So we offered only decompression at that L4-5 level with posterolateral grafting, and the fracture was taken care of with putting short pedicular screws at the fracture site and 2 above 2 below with the cross link. And he's done well post-op. There's a 1 year plus follow-up on this, and he's got better. So just a little bit of inputs on Parkinson's. Parkinson's disease with spine problems is an unfavorable combination. There's a lot of overlap between symptoms. So symptoms and functional deficits are frequently masked by Parkinson's. Parkinson's are known to have sagittal and coronal plane deformities. The outcome of spine surgeries are not satisfactory due to inherent muscle dystonia and osteoporosis. And progressive natural progression of the Parkinson's may contribute to unfavorable outcomes. So Parkinson's undergoing surgeries, this is, at least the lumbar surgeries is now rising. But if you ask which is the worst kind of a situation in which you can land up the Parkinson's with cervical spondylotic myelopathy, this kind of a combination is a very bad combination, because here we are used to seeing cervical spondylotic myelopathies get much better with surgeries. But here in cervical spondylotic myelopathies, with this, the recovery rates and the patient satisfaction rates are not as great. If it comes to a combination of lumbar fusion surgeries, because of these inherent deformities of forward stooping, then lumbar fusion surgeries with osteoporosis is showing high recovery rates as per the present literature till now. So this is to be kept in mind in regards to Parkinson's patients.
Sheetal, sir.
Yeah.
Sir, just one question. So,
Yeah, so
how do your counseling differ in the normal patient who undergoing surgery and like a Parkinson patient with the spine problems?
Yeah, very valid point, Tosif. So we essentially tell the patients that now in this case I operated here only for the clinical instability. So pain was the whole thing that was going to get better by surgery. So I tell these patients that this is the only thing that's going to get better by putting implants. I'm going to give support, and that's the only thing that's going to get better by doing surgery. Here are other things of needing support, mobilization, all these things will not get better by doing surgery. So I think so making it clear to the patient as to what is going to get better and what is not going to better is very important in Parkinson's, because there's a lot of symptom overlaps: numbness, difficulty in walking, movements are slow. All these things are not going to get better. Here in this case, only the axial instability is taken care of. So something similar needs to be made clear to the patients post pre-surgery counseling. Especially another thing, I have got a patient in which there was a spondylotic myelopathy plus Parkinson's. So this surgery was actually called off by the neurologist. The neurologist said that he wanted to optimize the patient on Parkinson's treatment and then decide whether he needs surgery or no. So this is someone. So basically, complete optimization of treatment of Parkinson's to the extent that the neurologist now says that I can't do anything more, may be a good statement to have to hear from the neurologist.
Yeah. And does like your post-op protocol in terms of mobilization differs with the patient with Parkinson's disease with spine problem? Basically, you go slow on them, or like you follow your regular protocol?
No, those follow the same ones. At least I have not seen. In this case also, just followed same things as what we do normally. Another case, 60-year-old male with a past history of brain procedure in past, and now complains of sudden onset pain in both lower limbs, left and the right more than the left. No medical risk factors and neurology grossly intact. So we had imaging for this patient, and that's the imaging that we have. So we see here that there is a significant stenosis at 4-5 and at L5-S1 at both these levels. And this is someone who was admitted and severe pain, rest pain at 4-5-5, and there is significant stenosis. The patient also had a hip MRI done. So the hip MRI showed there's bilateral avian in this case. So as I said, we are seeing more and more avians now in the spine clinics also. So this is bilateral avian in this patient. And so this patient had to be, so we did decompression in this case, and he has done very well post-op at the last two levels. But he was counseled again, and like the last case, he was counseled pre-op as to there are two etiologies to have to tackle, and we are tackling only the spine just now, and the avian may need to be tackled later on in case the hip pains and other things worsen. So this was consented on paper before that decision of spine surgery. So another important thing in which you can have this kind of a picture combination.
Sir, I want to ask one question.
Yeah.
In such case with AVN and as well as spinal canal stenosis or sometimes other etiological factors which leads to spine surgery. So in that case, which surgery should be done first? And also in the TKR cases also. So
yeah, so very valid point. This is what actually we brought up initial part of discussion also. So if it is going to be a lot of clinical thing along with radiological matching. So if I see a patient who has moderate lumbar canal stenosis, but on examination he's wincing in pain, the moment I bend his knee, he's jumping in bed, knee pains. Every time I ask him his primary complaint, he says pain in the knee, pain in the knee. Then even if that stenosis is seen on the MRI, I'm not much keen to offer spine as the primary surgery. Then I would be happy to refer him to a ortho person and then let him get back to us regarding whether he would be keen to offer such cases. So we have a lot of coordination with our orthopedic departments, with our orthopedic surgeon colleagues, in which we take a joint decision as to making the patient aware of what the problem is and why we are tackling which etiology first. But at the same time, if we have something like a severe lumbar canal stenosis with a ONE, with ONE not being so troublesome, then the decision is easier. If there's a ONE plus LCS in equal intensity and equally severe in presentation, then I would be keen to offer the spine first, because once I do the spine, the walking is going to get better. And once the walking gets better, the analysis about knee pain, whether relief of it or even worsening of it, will be better by the patient. If I do the joints first, the knee first, the patient is still not going to be up and about, because the spine is still yet to be tackled. So I would be keen to tackle the spine first and then the knee in that case of a scenario.
Thank you.
Yeah. So next one, please. Another interesting case, 69-year-old lady, hypertensive, IHD, hypothyroid on treatment, and sudden onset of severe back pain, not relieved with usual medications. So I remember this case being called to see this lady, but she was someone who was significantly in pain, like tossing and turning in bed. And somehow this kind of a picture was just not fitting. So earlier I had seen a case in which there was a young middle-aged male who had a similar presentation, severe back pain, not getting better. And we had asked MRI in that case, and that case eventually turned out to be a pyogenic abscess. So I was expecting that I'll see something similar here. So I asked for MRIs. So this is what the MRI showed. If you can see just behind, as it was the cursor, he is moving just behind in that spinal canal. We can see in the dural, intradural, if you see, there is a small amount of dark kind of a shadow going all the way down to the sacrum part. So if all that is going down into the sacrum, so that is the spontaneous subdural hematoma. So in this case, I learned about the second etiology that we have to keep in mind. If it is sudden onset severe back pain, other than pyogenic abscess, this is something more that you have to keep in mind. We did contrast studies in this. We have the next slides, please. So in fact, in this case, it showed that there was significant stenosis at one level, but the presentation was only back pain. There's no leg pain, no radiculopathy, no claudication, nothing. So this is the post-contrast axial at that level, showing that it is iso or hypo on T1 and iso or hyper on T2. So that went in favor of nothing infective. It was more in favor of a blood clot. And actually the contrast picked up that starting from D7 downwards. So that is what the final report came through as. So a bit of search on this showed, we did a brain scan also here, but the brain scan was done more to know whether there is anything higher up which is coming down, trickling down, that is the reason. But spontaneous subdural hematomas are known. Otherwise, subdural hematomas are most common because of trauma as the etiology, or with spinal epidural needles, punctures. But in this case, there was nothing like that. It was a spontaneous subdural hematoma. And the only other thing is blood thinners can be a possible cause in such cases. In this case, it was completely conservative treatment. We asked the neurosurgeon to be involved in this. But since the neurology was intact, other than managing pain and waiting it out, there was nothing else aggressive. In fact, he asked for the brain scans to be done to rule out if there's anything higher up. And seeing that there was nothing higher up, he was quite relieved. And the patient got better in around 3 to 4 weeks. But this was a significant, this was another important cause to keep at the back of the mind if there is sudden severe back pain at presentation. We have next one.
Sir,
yeah, tell me please.
Sir, this artery of Adam Chavez, sir, it might have a variable origin from D7 to L2. So could that be a possibility? Some kind of aneurysm in artery of Adam Chavez and then, leak and then this thing happening, or not at all?
No, I mean, whatever we have read through, at least whatever little I've read through, is more it can be a vein rupture usually. And
Okay.
usually that happens between the arachnoid and dura.
Okay.
And they're saying dorsal is the more predominant level that you can land up with this kind of a problem. Spontaneous ruptures. We're not talking about anything traumatic. We are saying about spontaneous.
Ji, sir.
Yeah. Okay, we go to the next one again. Yeah, this is, I think so. I'm nearing the end of my talk now. very interesting. Till in this over 15 years of practice, I've seen only 3 cases of osteostomas. We are looking at only spine, of which these 2 have been spine. One has been spinous process, which was knocked off, and one was in the pedicle, which no follow up with me. It went on to a senior surgeon. But the third case is a very interesting one, because this is someone who came through with neck pain and arm pain, that kind of presentation. More of arm pain. Neck pain had resolved, but it was complete arm pain. 2 MRIs done, and both the MRIs showing it was non-compressive. Someone had asked for EMG. EMG also was normal. But this fellow was just not relieved of the pain. The pain was persistent. So having gone through both these investigations, which we normally do, there was no point in repeating anything else. So I asked him to do a bone scan. The bone scan surprisingly picked up an osteoblastoma in the humerus. And that completely explained why this person was having persistent arm pain. And he wanted to get it done via, after explaining the options to him, he wanted to get it done via radiofrequency ablation. And he ultimately went to some top radiologist in Bombay. So this is the third case, I feel. So this is a important, another way rare etiology that you can keep in mind if everything else is been sorted out. I think so. I'm nearing the end. Then I think I'll go on to the conclusion slide. I think so. A proper history, a clinical examination is a must. Always have a clinical radiological matching done. If things do not match, do involve other specialties and discuss the etiology for the present situation and then treat accordingly. I thank you all for this lovely session that we had today. Thank you. Thank you, Joseph, for this doing a great job for me.
डॉक्टर
Thank
मोहिते
you, sir.
सर आई वाज वंडरिंग कि सर वो जो न्यूरोलॉजिस्ट ने बोला कि सर्वाइकल स्पॉन्डाइलेटिक माइलोपैथी को मतलब ऑपरेटिवली वेंचर करने से पहले मैं पार्किंसन ठीक करूंगा, सर वो इसलिए मतलब कंसर्न है कि मरीज ज्यादा गर्दन हिलाएगा तुम इम्प्लांट डाल दोगे, इम्प्लांट लूज हो जाएंगे. इज दिस द थिंग?
No, I was not planning for any implants. But the symptom overlap in a cervical spondylotic myelopathy and a Parkinson's is so much that it is difficult to, because there is rigidity, spasticity, walking difficulty, imbalance, all that fine function affection, tremors, all that is too much to an extent. So that's a very bad combination if you ask for a neurologist thing. So he felt probably that he could get better, and that's why he felt that he could optimize him. And then but literature wise also that's a bad combination from a surgeon's perspective. So
And
eventually,
also it has some amount of anesthesia and perioperative risk also. So I think optimization sometimes is required, especially when it's a rapidly progressive or a severe Parkinson's.
So I think so good that he intervened and asked me to get off that case.
Thank you, sir.
Yeah.
So
Sir, I wanted to ask one question. In some patients of Syrinx formation in cervical spine, there are chances of neuropathic joints in shoulder joints, etc. in later condition. But in initial stages, how can you differentiate with other conditions in Syrinx formation?
Syrinx, at least I have not seen with whatever little we have seen, we have not seen great huge syrinxes. But if we do see some great huge syrinxes, then usually we ask the neurosurgeons to consider a shunt procedure. So I have no inputs on this other than huge syringes being managed with neurosurgeons for shunt procedures.
So there have been few follow-ups in the OPDs for I have seen couple of them, bigger syrinxes also, but when they were clinically silent, we have not done anything for them largely. But if there's a clinical implications, then definitely neurosurgeon got involved. I think we did not have anything to do about that.
Yeah.
Yeah. Any more questions?
Any more?
Excuse me.
Sir, yeah. Please. Yeah.
So in the case of the patient with the bilateral avian hip along with the spine things, what made you do the MRI of the hips in that case, sir? Was there tenderness in the hips, or why did you get the MRI done?
No, it was done by the referring orthopedic before he came to me. So it was,
Okay, sir.
yeah, so it was just that it was there.
Okay. Okay. Thank you, sir.
Yeah, yeah.
And any which ways, the amount of like symptoms or clinical implications are more important for us, even if it comes to us. I think if something is not matching, better investigate in today's day and age.
True, true.
Sir, how often now, I mean, what is your threshold nowadays to get a contrast MRI done? Because I have found some interesting things in last couple of months, getting contrast MRIs done for some patients.
Yeah, very true. It's a very important investigation. Actually, we have not covered in this talk, but any intradurals and all, they do light up in this
So you
contrast.
So you mentioned just in passing, but I recently
Yeah.
operated a gentleman. 3 months he's taking treatment of painkillers every day. Well, I might have the images also in my iPad. Uh,
True.
Treatment every single day, multiple painkillers, not getting better. MRI is absolutely clean, the normal MRI. And then he came to my OPD. I said, "Was something is not matching? Let's get a contrast done. Let's see what." Nothing lost. We
Perfect.
got a contrast done, and he had a large pyogenic abscess in the psoas and some involvement of L4 and L5 peridiscal region, anterior aspect. And I don't know whether it was an intraosseous compression or a large psoas abscess, what led to it, but significant pain. And biopsy, then I did biopsy, but biopsy turned out to be no inconclusive, no nothing. Then we had to operate him because he was in tremendous pain. And then on IV antibiotics, is an empirical I mean, kind of an antibiotic which is broad spectrum, and I think is improving. Yeah,
Oh,
just
fantastic.
operated 2 weeks back. But I think my contrast, like last 3 or 4 cases where contrast MRI was kind of to find out what's happening inside. I mean, I've got some interesting results in contrast MRIs.
Very true. It's a good investigation in armamentarium in case we are finding something which is not matching. So I completely agree with that statement, Arshad.
सर अ नाइव क्वेश्चन सर अगर अगर सर कंट्रास्ट डालने से फायदा हो जा रहा है तो सर सबका ही कंट्रास्ट क्यों ना कर लिया जाए सर?
No, no. It's a
So
very
many things, sir.
significant thing.
Cost, everything.
Cause you
And
need to have good kidneys, you'll fire kidneys. So I think
I
so
think it's
that is
better.
more asked. If the pathology is clinically very much evident, then you don't need contrast for it. I think so that's more important as to in which you are not able to match your etiologies, or you are not able to tell the pathology causing the symptoms, then only you can think of contrast. So I think so that's a very if and then kind of a situation, not a blanket for all.
True.
Right, sir. Right, sir.
Any more questions, guys? A very interesting topic. So many things to talk about. Anyone? Any good cases which you have come across?
Excuse me, sir.
Yes.
Yeah.
Sir, just deviating a bit from the topic, I just wanted to ask in case of this METS cases, and Dr. Nene also said that he would go in and operate on the day, and today also you showed a case where you had operated. So we were taught that in these cases, there is always a possibility of the metastasis or the cancer cells seeding through the soft tissue from which you are entering or you are handling. So is that thing really clinically relevant, or was it a overhyped sort of thing? I mean, once you go and disturb the cancerous or the tumorous cells, we were of the opinion that it kinds of tracks through the soft tissues that you have gone through. So does that actually happen, or is it a myth kind of a thing?
I have not come across that kind of a situation, but I think so. Neurology carries a big sort of bearing on this decision making. So if it is going to be someone who's a walker and other things, we generally can wait it out, look out for the primary, do a complete workup, and then take it from there. But if it is someone who is with a deficit, with a non-walker kind of a status, then you are looking at going in. But the only other thing I would keep in mind is our colleagues who are going to be taking over for adjuvant, they need the skin healing to be good.
Yes, sir.
So that's the only standing I would take. Other part, I'm not much convinced. But adjuvant therapy, if it has to be initiated early, then they need a good skin healing to be as a prerequisite for it.
Okay, sir.
You,
Thank you, sir.
Harshal, you can add if
I
you have
think,
anything else.
yeah, I think it's very rightly said, sir. The risk benefit ratio,
Yeah.
and at the end of the day, we don't just take out a tumor and leave it be. There's always some amount of chemo or radiotherapy which is going to go on. So I believe when there's a nerve involvement or an instability which is impending nerve involvement, I think that's first thing we should discuss, and then think about if it can happen, the seeding and everything. Yeah.
Okay, sir. Thank you so much.
So, डॉक्टर मोहित है
Yes, sir.
सर एक चीज सर आज
Sorry, Nitin, your voice is cracking.
आया था तो मेरे को लगा एक बार
नितिन जी, आपका आवाज थोड़ा अटक रहा है,
Nitin, your
कुछ तो
voice is
गड़बड़ है।
cracking, Nitin.
कुछ मुझे ज्यादा समझ आ जाए.
Sorry, Nitin, we couldn't hear your question because your voice was
Yes, sir.
cracking.
Yeah, sir. Is it clear now, sir?
Yes, much better.
Yeah, sir. I was saying, sir, a 55-year-old male reported that patient had loss of appetite for last 6 months.
Right.
And almost stopped eating chapatis, something like that, for last 8 weeks.
Okay.
For last, and just 1 month before, patient had some, his foot stuck somewhere, and then there was some swelling in the left foot.
Okay.
And in the last 2 weeks, patient becomes non-walker.
Okay.
And for the last 5 days, patient is passing urine in bed.
Okay.
Now, when I got the call, so this is the position when I got the call.
Understood.
Patient was already catheterized. And as far as the history is concerned, patient already had a triple bypass done in the past. On clinical examination, both the lower limbs are hypotonic.
Okay.
Areflexic. And power is around 3-.
Okay.
And the upper limbs are also hypotonic and areflexic. But their power is around 4.
Okay.
There is no respiratory compromise on the patient side, but abdomen looks to be quite distended and dilated veins and that kind of an abdomen. And left inguinal region shows a large cluster of some clumped lymph nodes kind of a thing.
True.
So that kind of a thing present, and on his left foot there was this. So there on his metatarsophalangeal area there was a huge swelling like a small cricket ball.
Okay.
And there is a mouth, there is an opening to it, but nothing was expressed out of it.
Okay.
Then I looked at the investigation, sir. Patient hemoglobin was 10.4. Patient ESR was 102.
Right.
CRP was 35.
True.
Kidney function test all okay. Liver function test all okay. Sugar is all okay. Vitamin D3, B12, all those things are all okay.
Okay.
When looking at the patient X-ray of the foot, because I got the call for the foot, so there was a mass effect kind of an X-ray which is present. The disease was involving almost the whole of the metatarsal.
Okay.
And there was a pathological fracture toward the apex of the metatarsal.
Okay.
And then there was eccentric dystrophic calcification, very, very multiple kind of, which was very unusual to see in 1 month in any kind of an abscess. I have not seen abscess having like that. So I thought ये तो कोई fungating mass है. So that thing came to my mind. तो फिर मैं बायोप्सी, मैं उसको मतलब INT नहीं किया जो INT के लिए मुझे बुलाया था.
बराबर.
फिर मैं बोला कि मेरे को पैर में ऐसा दिख रहा है, तो मेरे को पैर का CE MRI करा दो.
ओके.
किडनी ठीक है उसका, तो उसका CE MRI करा दो. और जो उसकी स्पाइन है, तो मेरे को लगा पेशेंट को साथ में ये जो प्रॉब्लम हुआ है, कहीं कहीं कोई वर्टिब्रल लेवल पे कुछ हो गया होगा।
राइट
तो मेरे को एक स्पाइन का भी दे दो करके।
राइट।
आपका क्लिनिकल डायग्नोसिस क्या था?
सर मेरा क्लिनिकल डायग्नोसिस जो इस पेशेंट में था, सर मेरा मेरा जो मैंने सोचा कि इट इज पॉसिबली अ मेटास्टैटिक डिजीज विद अननोन प्राइमरी,
हम्म
with with acute onset quadriplegia, could be some sort of evolving Guillain-Barré.
ओके
What is the age of
Something
the
like,
patient?
sir, patient is 55, sir.
55.
हाँ सर।
Okay.
तो सर फिर उसके बाद फिर मैंने ये सब जांचें लिख दी, फिर वो उन जांचों की रिपोर्ट आ गई। सर रिपोर्ट में इंसिडेंटली जो वो था मेडिसिन वाला बंदा, उसने पेट भी करा लिया।
ओके।
अब शुरू करते हैं, नीचे से स्कैन देखना शुरू करते हैं। सर उसके उसके जो फुट वाला है, फुट के एमआरआई में बोल रहे हैं कि बेसिकली एक 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 हाइपर डेंस काइंड ऑफ अ लीजन प्रेजेंट है फुट के अंदर में, और साथ में उसके अंदर में एक पैथोलॉजिकल फ्रैक्चर है। तो उनका जो प्राइमरी सस्पिशन है कि इट कुड बी एन इन्फेक्टिव क्रॉनिक ऑस्टियोमाइलिटिस, बट दे गिव अ क्वेश्चन अबाउट माइटोटिक पैथोलॉजी।
ओके
ओके
ठीक है, नंबर 1। नंबर 2, सर पूरी की पूरी जो स्पाइन है, सेक्रम से के नीचे कॉक्सिक्स, सर कॉक्सिक्स से लेकर के सर्वाइकल तक पूरी की पूरी स्पाइन क्लीन है, स्पाइन में कुछ नहीं है,
फैंटास्टिक। हाँ
स्पाइन एकदम चमक रही है। और सर जो पेशेंट की चेस्ट है, चेस्ट के अंदर में बायलैटरल छोटे छोटे अनगिनत चीजें प्रेजेंट हैं, कुछ कॉटन बॉल जैसी बहुत सारी। और जो एब्डोमन है, एब्डोमन के अंदर में पूरी की पूरी रेट्रोपेरिटोनियम भरी हुई है।
ओके।
पैरा आयोटिक, फिर ऊपर में सर मीडियास्टाइनल, हाइलर, सब लिम्फ नोड भरा हुआ है उसके अंदर। और
ओके।
जो लेफ्ट वाली साइड में जो मैं वो गुच्छा देख रहा था लिम्फ नोड का, उसके अंदर में एक बड़ा सा, मतलब साइज वाज वेरी लार्ज सर, इट वाज लाइक 6 सेंटीमीटर इनटू सम 4.5 सेंटीमीटर, दिस लार्ज साइज
ओ माय गॉड। हाँ
थिंग इज प्रेजेंट इन द लेफ्ट इंग्वाइनल रीजन।
हाँ हाँ।
और फिर ब्रेन के अंदर में भी ऑक्सीपिटल रीजन में, सब फेल्साइन एरिया में लेफ्ट साइड में 2 नेक्रोटिक लीजन प्रेजेंट है।
ओके।
तो सर जब ये सब देखा, तो सर फिर जो मैंने फिर सोचा, मेरे को ये लगा कि हालांकि मेरे को अभी तक प्राइमरी नहीं पता है, पर ये एक एडवांस्ड मेटास्टैटिक डिजीज है। और इस मेटास्टैटिक डिजीज के अंदर में ये जो स्पाइन का जो लोचा मुझे दिख रहा है, ये लोचा हुआ है बिकॉज ऑफ सम पैरानियोप्लास्टिक सिंड्रोम। इस पैरानियोप्लास्टिक सिंड्रोम ने इसको कुछ गुलन-बरे जैसा बना दिया है।
ओके ओके। हाँ हाँ।
सर ये स्टेटस है। अब मैंने
That
आज मैं
is
बोल के
what
आया
you
हूँ
are.
कि प्राइमरी नहीं पता है तो उसके इंग्वाइनल नोड निकाल देते हैं एक, और फिर उसकी बायोप्सी चली जाएगी। सर ये स्टेटस है सर, ऐसे घूम रही है। अब कुछ
So
क्वेश्चन आप
that
पूछना
is
चाहें या बताना चाहें तो बताएं सर।
no. I feel in your case that is the most obvious thing. Have a biopsy done. But
हाँ
another option I can think is it something like a disseminated cox or something like that
करेक्ट
with
सर,
myelitis.
सर दिस वाज माय सेकंड आइडिया कि ये
With
डिसेमिनेट कॉक्स हो सकता है। तो
myelitis.
सर वो जब सैंपल निकलेगा ना सर,
हाँ हाँ।
तो सर उस सैंपल को सर फिर वो जो आदित्य काशीकर सर ने पढ़ाया था, वो सारे 8 टेस्ट करा देंगे।
Right right right.
हाँ
बेसिकली उसका
Very-
टोटल काउंट और डिफरेंशियल काउंट भी देखिए, शायद दैट कैन गिव यू सम क्लू।
सर टीएलसी
very
डीएलसी,
हम्म।
हाँ सर वो 10,000 के आसपास है सर, वो मैं देखा था सर। सर वो सब ठीक था सर।
डीएलसी में कुछ भी नहीं था ना, बेजोफिल्स इओसिनोफिल्स कुछ भी नहीं था।
हाँ नहीं सर, नॉर्मल सा पड़ा था सर।
अच्छा, तो फिर ठीक है, तो बायोप्सी विल गिव यू सम अमाउंट ऑफ रेस्पाइट
See,
एटलीस्ट
and
क्वेश्चन।
what Harshal suggested, we can consider a contrast in this case because
हम्म।
otherwise you can pick up something like myelitis, which can completely explain this kind of a neurology also.
हाँ
Because
नहीं एक्चुअली सर उसका सारा कंट्रास्ट
nerves,
ही हुआ, क्योंकि एक बार कंट्रास्ट
अच्छा
डल गया ना,
contrast हुआ.
तो फिर पूरा का
Okay.
पूरा कंट्रास्ट में निकाल दिया उसको।
अच्छा 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 अच्छा.
हाँ 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 हाँ।
एंड पेट डिडंट पिक अप एनीथिंग ना, पेट में कुछ नहीं था ना।
नहीं 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 सर, मैंने बताया ना सर, ये जो सारी बातें
हाँ
बोली
वो तो सारी बातें
यहाँ
बताई,
भरा
पर
है वहां भरा है सर, सर पेट
अच्छा
में भी यही सब बोला।
अच्छा अच्छा अच्छा, ओके, फनी। let us keep us updated what happens to that
Keep us
case.
updated. Yeah, very
तो
interesting
सर
case.
मैंने सर
Yeah.
अपने सर सर्जिकल ऑन्कोलॉजी फ्रेंड से बात की, उसने बोला भाई इसका तो जो कार्नोफ्स्की, सर मेरे को पता नहीं क्या होता है ये, कार्नोफ्स्की परफॉर्मेंस स्कोर इसका इतना ज्यादा गया हुआ है कि इस बाबा को तो मतलब पैरासिटामोल लेके घर भेज दिया जाए, तो इतनी इसकी आगे जांच वांच कर रहा है, बट स्टिल टू बी अ डॉक्टर तू उसका सिर्फ एक बायोप्सी करके डायग्नोसिस प्रूव कर दे, बाकी इसका कुछ नहीं हो सकता, ये निपट गया।
I
True,
think so.
multi-system
Diagnosis is
involvement.
important.
Yeah.
Suppose it comes out to be COX, then he can still be revived. Then if it is
Yeah.
something else, then it can be something very bad.
Got the
also.
point, sir. Got the point, sir. Yes,
Yeah,
sir. Yes,
yeah,
sir. Yes, sir.
yeah.
So COX, fungal, parasitic, all these can be the
Yeah.
issues here.
Yes, sir. Yes,
and also definitely your first diagnosis is a metastatic disease. That's
Yes,
that's
sir,
the
yes,
first one. First 1, 2, 3 maybe that. But
हाँ
after this, there are a couple of other diagnoses which can have treatment.
जी
per
सर,
se.
आई वाज
Yeah.
वंडरिंग सर हैज एनीवन सीन, सर इस जो मैं देखा सर, हैज एनीवन सीन डिसेमिनेटेड कॉक्स ऑफ दिस वैरायटी सर?
I don't think nowadays we see as
Yeah.
much, but I think
Yeah,
Sheetal
yes.
sir would
Sir,
put a light
is
in
there
that.
any chance
Uh,
of primary in the bone?
Actually, this is what something I was discussing out with Tausif just day before yesterday when we were operating, but not the disseminated part, but just that TB dactylitis I saw after a long time. So this was something we are seeing, and we have means if it is still being seen in places like Bombay, then I'm sure it must be seen somewhere also. So TB dactylitis after our passing out, I had never seen, and this is after so many years I saw that. So I think so. I'm still keeping COX as one of the diagnosis.
नहीं सर, सर कह रहे सर वो
Sir, is there
डेक्टिलाइटिस तो
any
है, लेकिन मैं
chance
कह रहा
के
हूँ सर
primary is
पूरे शरीर में इतनी सारी भरी हुई है सर, वो टीबी हो सर, मैं तो सोचा कि
I'm
लिम्फोमा
praying
लिम्फोमा
for
ही ना
that
हो,
actually. I'm praying
लिम्फोमा
for
ही
that.
ना हो।
Yeah, yeah.
जी
So,
सर।
like
Yeah, someone was
one
asking
of the
something. Yeah.
remote thing which comes into my mind is like non-Hodgkin one.
या आई वाज सेइंग लिम्फोमा,
Yeah,
यस सर,
Tausif.
यस सर, यस
That's
सर,
also
यस
a
सर।
diagnosis. Yeah.
So, like keep that also in the mind and like work up for that also.
सर वर्कअप में थोड़ा सा गाइड करेंगे सर, थोड़ा सा है ना, ताकि मैं पढ़ पाऊँ बाद में फिर वर्कअप के बारे में क्या सर?
So, like
Yeah.
Tausif
as
sir,
a
Tausif
yeah,
sir, can I add one thing, sir?
maybe chances of eosinophilic granuloma?
yeah. Please, Pranav.
Sir, if it is a non-Hodgkin's lymphoma, we used to, if it is better to see one USG abdomen pelvis also.
So they have done the MRI
Better
with
contrast हो गया रे.
हाँ सर, वो तो सर जो सीई एमआरआई है ना, सीई एमआरआई के
उसमें
अंदर
सब हो
में
गया.
वो जो सब कुछ आ रहा है कि जो जो पेरिटोनियम है और सर वो जो वहाँ फैट वैट होते हैं वो सब स्टैंडर्ड हो गए हैं और
I think
लिम्फ नोड बड़े हो गए हैं, ऐसा
I
आ
think
रहा है।
Nitin, the
But it is,
best diagnosis for you is tissue diagnosis.
या
I think you get
and
you
if
get
it
your
in,
you get your
in
biopsy done, and I
Yeah.
think that will solve, I think, most of your queries. At least you will get a diagnostic line, and then depending upon what comes in the biopsy, maybe you can investigate further.
राइट।
Yeah.
and
So-
in USG we like to see the renal echo texture and liver echo texture. So usually if it is a non-Hodgkin's, as Dr. Tausif sir is saying, you will get a rough idea of the non-Hodgkin's lymphoma according to that.
Yeah, but Pranav, like use to come into like kidney echo texture, or for that matter, the splenic echo texture, it is non-Hodgkin if I am not a grade 3 or grade 4. So this has almost the cross that limit, but again, you can do that, but since he has like patient in hand and great this thing to do biopsy, I would suggest he should do biopsy from the lesion as well as the lymph node, basically. So he should send a lymph node along with the local tissue for the biopsy.
नहीं, मैं सर लोकल में कह रहे वो जो
Hello?
फुट के अंदर में जो लीजन है, फुट वाला
Hello.
सर, फुट वाला
Along with
लीजन।
that, sir, I'd like to add one thing, sir. Along with that, you can do a bone marrow aspiration also. Will get an idea also.
डॉक्टर तौसिफ, हेलो 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 हेलो
Tosif is not.
Dr. Tausif is, I think so, he is not there.
He is not on the
ओके
line.
ओके ओके
listening.
हाँ डॉक्टर मोहित, सो आई वाज, अच्छा 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 अच्छा। तो सर मतलब एक नई बात सामने आई कि सर वो जो कह रहे हैं कि दो साइड से निकालो, तो सर एक तो फुट से निकालने को बोल रहे हैं और दूसरा
हाँ,
बोल रहे हैं
और
इंक्वाइनल
lymph
लिम्फ
node
नोड
से
से
बोल
निकालो।
रहे हैं, बराबर lymph node
सर
से बोल रहे
सर
हैं।
वो दो से निकालने को क्यों बोल रहे हैं सर?
I think so. He must be trying to get more and more evidence. That's the only thing
अच्छा
I can.
अच्छा 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 अच्छा।
In Sir Tausif sir's view, I think so. If you are searching for anything pathology,
या
if you are taking from the foot, you will get to clear whether it is an infective pathology or whether it is a uh,
हाँ हाँ हाँ,
metastatic one. And
I see what Dr. Moite was suggesting. Got it, sir. Got it.
yes, as sir suggesting
Yeah.
the same thing. And with lymph node biopsy, you will get to know the clear picture.
Yeah.
Whether it is
Yeah.
a tubercular or whether it is a only lymphadenopathy
Yeah.
because of other causes.
या या सर मैं कह रहा हूँ सर, ये तो इसको तो क्लोज करते हैं सर, ये तो मैं करूंगा कल। सर ये कह रहा हूँ एक केस और बताऊं सर, अगर इफ पीपल हैव टाइम।
Yeah, we have time. Come on, go on.
सर another 52-year-old male, a policeman by profession, a thin sturdy built guy, doing very well till 2016 in his life, when he developed renal cell carcinoma. Whatever would have happened, but it was proven to be left side renal cell carcinoma. So
Right,
that renal cell carcinoma was subjected to a radical left nephrectomy,
right.
and then patient was given radiotherapy, and patient was put on a biological drug known as pazopanib.
Okay.
And patient is taking pazopanib from 2016 till date. And now he presented to me in OPD around 6 weeks back.
Okay.
And he complains of mid dorsal back pain,
Okay.
and it has all the red herring signs. It is mid dorsal in nature. It is even pain at rest. There are night breakthrough pains. There is a feeling कि सर पसीना आ रहा है, नाइट स्वेट ऐसे हो रहा है, और लेकिन लॉस ऑफ एपेटाइट बिल्कुल नहीं है।
बराबर।
मैं सर पेशेंट को ये सारी की सारी बातें सुनी, और ये सारी बातें सुन के मैं उसको CE-MRI लिख दिया। सर वो उसी दिमाग से कि मैंने सर कुछ ये दिमाग में नहीं लगाया कि पहली वैरायटी सेकंड वैरायटी, मैं सोचा क्या पता जानकारी ज्यादा ही मिल जाए, ऐसे करके मैं सर CE-MRI लिख दिया। वो CE-MRI करा के आया, तो उस CE-MRI जो करा के लेके आया, तो उस CE-MRI में रिपोर्ट किया उसने, रेडियोलॉजिस्ट ने, कि पेशेंट के D10 के राइट साइड के पेडिकल में, D10 के राइट साइड के पेडिकल में डिस्ट्रक्शन है।
बराबर।
और वो जो डिस्ट्रक्शन है वो एनक्रोच कर रही है टुवर्ड द सेंट्रल कैनाल एंड टुवर्ड पैरावर्टिब्रल एरियाज आल्सो।
ओके।
और जो वर्टिब्रल बॉडी भी है वो भी थोड़ी सी मतलब सर पिचक गई है आगे की ओर, एंटीरियर वेज कंप्रेशन हो गया है।
ट्रू।
लेकिन कॉर्ड के अंदर किसी प्रकार का कोई चेंज नहीं है, और सर पेशेंट रिफ्लेक्स वाइज, मोटर वाइज, एवरीथिंग पेशेंट इज डूइंग वेरी वेल,
इंटैक्ट।
इंटैक्ट है मामला एकदम पेशेंट का। अब जब उसकी ये रिपोर्ट आ गई, हाँ एक बात, हाँ लेकिन जो रेडियोलॉजिस्ट था, क्योंकि मैं बार बार उसी को भेजता हूँ, तो उसने देखते हुए पेशेंट का एक वो भी कर दिया, CE एब्डोमेन भी कर दिया, क्योंकि उसको देखते हुए रास्ते में लगा होगा। तो उसने बोला कि पेशेंट की जो टेल ऑफ पेंक्रियाज है ना, टेल ऑफ पेंक्रियाज में भी एक लीजन है।
ओ हाँ।
टेल ऑफ पेंक्रियाज में भी लीजन है। और फिर ये दोनों की दोनों चीजें लेके मेरे पास भेज दिया। जब
ओके।
ये मेरे पास आ गई, तो फिर मैं अपने मेडिकल ऑन्कोलॉजिस्ट से बात किया कि मैंने कहा भाई मेरे को ये दो बातें मिली हैं, तो मैंने बोला कि मैं आपके साथ आगे इन्फॉर्मेशन शेयर करूंगा जब मैं बायोप्सी कर लूंगा। फिर मैंने C-आर्म गाइडेड उस D10 पेडिकल के अंदर में डाल दिया।
ओके।
अब वो टिश्यू डायग्नोसिस आएगा सर, मैं 1-2 दिन का मेरा समय लग रहा है टिश्यू डायग्नोसिस में। तो लेकिन अभी जो मेरे दिमाग में जो बात बन रही है, वो बात ऐसे बन रही है कि जो टेल ऑफ पेंक्रियाज है ना, वो बिल्कुल वहां पर पड़ी होती है जहां पर किडनी पड़ी होती है। तो उस जगह में जो टेल ऑफ पेंक्रियाज के अंदर में जो लीजन आया है, वो तो एक प्रकार की रियकरेंस है। और ये जो लीजन है, ये लीजन डिस्टिंक्टली दूरी पर है मेरी स्पाइन के लीजन से।
ओके,
तो मेरा स्पाइन का लीजन रियकरेंस नहीं हो सकता, स्पाइन का लीजन तो मेटास्टैटिक इन नेचर होना चाहिए।
मैट ही रहेगा।
हाँ, मेरा स्पाइन का लीजन मेट रहेगा। अगर
हम्म
तो अगर ऐसी सिचुएशन है जैसा मैंने बोला,
हम्म
तो और मेरी मेरे मेरे मान लो स्पाइन, मेरे स्पाइन की बायोप्सी से कुछ रिजल्ट आता है, जो भी रिजल्ट आता है, ठीक है,
हम्म।
तो जो सर अभी सर हो सकता है अब इसके आगे थोड़ा सा मैं लूर साउंड करूं, बट मुझे करेक्ट कर देना सर, कि सर
नो नो,
मेरा
टेल
प्लान, सर मेरा प्लान है, मतलब मेरे मन में ये भाव आया
हम्म
कि वो जो हमको पढ़ाया था ना, बेरियारी, विंस्टाइन, बोरियानी का जो
हाँ
एक
हाँ
तरीका
Correct.
पढ़ाया था, वो क्लॉक वाला।
हाँ हाँ,
WBV,
या
WBV
यस
हाँ,
यस
classification.
अब वो
Yeah.
जो
हाँ
पढ़ाया था, वो
हम्म
जो पढ़ाया था उसके हिसाब से इस पेशेंट की ऑ ब्लॉक स्पॉन्डाइलेक्टमी होनी चाहिए D10 की।
ओके, हाँ हाँ
तो क्या करेंगे कि जो मेरा जो सर्जिकल ऑन्कोलॉजिस्ट फ्रेंड है, उसको लेकर के पहले एब्डोमेन खुलवाएंगे,
हम्म
एब्डोमेन खुलवा के उससे वो वाला लीजन निकलवाएंगे जो
हम्म
टेल ऑफ पेंक्रियाज वाला है।
हम्म
जब वो टेल ऑफ पेंक्रियाज वाला लीजन निकाल के दे देगा,
हम्म
फिर उसको बोलेंगे कि हमको रेट्रीपोरिटोनियली हमको D10 पे ले जाओ।
हम्म।
और हाँ, नहीं नहीं, सॉरी सर, सर मैं एक स्टेप भूल गया सर, पहले हम पेशेंट को पोस्टीरियरली, जो पेशेंट का जो हेल्दी वाला
पहले
पेडिकल,
पोस्चर ले जाइएगा.
पहले
Yeah.
पोस्टीरियर
पहले.
जाऊंगा। हाँ सर,
हम्म,
पीछे से जाकर के जो उसका हेल्दी पेडिकल वाली साइड है उसको काट देंगे,
काट देंगे बराबर।
ताकि चीज नाचने के लिए रेडी हो जाए।
हम्म
और सर फिर उसको बोलेंगे पेट से खोल, पेट से खोल के बोलेंगे कि तू पहले अपना काम कर ले, टेल ऑफ पेंक्रियास निकाल ले, फिर उसके बाद में
हम्म
मेरे को D10 दे दे, और सर फिर मैं उसकी ऑ ब्लॉक निकाल दूंगा, और फिर
हम्म।
पेशेंट को पलट के उसको उसको फिर पेडिकल मार देंगे। सर ये सर प्रोविजनली सुनने में ओके लग रहा है, नहीं लग रहा है सर? मैंने आर्टिकल वगैरह पढ़े हैं, आर्टिकल भी कुछ ऐसे ही बोल रहे हैं।
आर्टिकल्स,
Actually, आपके
हाँ
मतलब it will be very much dependent upon the exact geography of the tumor.
राइट।
आपने
सर मैं
जैसे
शेयर
एक्सप्लेन
करूंगा
करा
सर,
वैसे.
मैं शेयर करूंगा सर,
हाँ.
जैसे ही वो पेशेंट एक दो दिन में आता है मैं स्कैन शेयर करता हूँ सर।
And it's perfectly all right what you said.
हाँ
Basically, anterior jana. I think
हाँ
the only trick remains that you want to go transperitoneal, retroperitoneal. Because if you want to take out the pancreas, you'll be kind of ending up going transperitoneal. So you want
हाँ
to take that up late on a later date, the surgery for pancreas.
हाँ,
But
ओके।
otherwise, taking out the spine in toto, if there's no epidural spread, there's no contraindication to do en block.
जी
That's what
जी
you'll have to see. Yeah,
जी
yeah.
जी 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 जी। थैंक यू सर, थैंक यू सर।
So, Nitin,
नाइस।
हाँ सर, हाँ सर।
uh, he had, if I'm heard it clearly, he had a right-sided RCC,
नहीं सर, लेफ्ट RCC सर।
left RCC. Okay.
सर RCC लेफ्ट है और पेडिकल राइट है सर।
Okay. So, just to like tell you about the tail of the pancreas and tumors of the tail of the pancreas, metastasis in the tail of the pancreas are extremely rare.
जी
The primary tumor of the tail of the pancreas is cystinous mucous cystadenomas.
जी
These
जी
are the
जी
primary tumors of the tail of the pancreas.
जी
Number one. Number two, if like adrenal are not infiltrated with the RCC, there are very rare chance that there could be direct inoculation in the tail of the pancreas.
जी
Number
सर, जी सर।
and
I just butt in here. I must have not heard the complete story, but
yeah.
have you done a pet for him? पेट
हाँ जी,
करा हुआ है
यस
इसका?
यस सर, ये सर पेट हो गया, और सर पेट के अंदर में भी बस ये दो ही बातें हैं जो मैंने बताई हैं सर, और कुछ भी
ठीक
नहीं
है,
है।
ठीक है, ठीक है, ठीक है. Please
हाँ
carry
सर,
on,
हाँ
Tausif.
सर,
Yeah,
हाँ
yeah.
सर।
Okay. Second thing, you said which vertebral lesion?
सर D10
D10.
राइट पेडिकल।
D10 right pedicle.
हाँ सर, वो जो टेल ऑफ पेंक्रियाज है ना, वो
Correct?
L1 पे जाके टच करती है किडनी को।
ठीक है. So,
हाँ
like to access D10, you have to go transdiaphragmatic.
जी जी
So you are like breaching the boundaries, like you are the principles of tumor surgery says you should not breach the boundaries basically.
जी सर.
Hello.
हाँ जी सुन रहा हूँ सर.
So you are like taking abdominal cavity into thoracic cavity or abdominal tumor into thoracic tumor.
But also if he wants to do a complete clearance, okay, it's gonna be an interesting decision whether to do it or not do it. Definitely there are options of doing thoracoscopy and handling two cavities differently altogether.
Yeah. So that's what I'm coming to. He should handle both the cavities separately and not in the same incision. Number one. Number two, you should ask your onco guy about the expected life or life expectancy of that patient, because pancreatic tumors are very much aggressive and life expectancy of the patient is very less.
नहीं मैं कह रहा हूँ सर, लेकिन सर ये पैंक्रियाटिक ट्यूमर तो नहीं है ना, ये तो पैंक्रियाज के अंदर में कोई रिकरेंस हो गई है सर. मैं कह रहा हूँ सर ये पैंक्रियाटिक ट्यूमर तो नहीं है, ये तो पैंक्रियाज में सर मैं ये कह रहा हूँ सर ये जो हाँ.
So that's what I put it as my first point. Metastasis to pancreas is rare, and the primary pancreatic tumors are more common than metastasis to the pancreas. So
नहीं सर मैं ये कह रहा था सर, नहीं सर मैं ये कह रहा था कि सर जब वो ट्यूमर को निकाल रहे होंगे आरसीसी, जब आरसीसी निकल रहा होगा तो थोड़ा बहुत आरसीसी स्पिल कर गया होगा उस एरिया में, और आरसीसी स्पिल करने की वजह से टेल के ऊपर में गंदगी लग गई और फिर टेल ने ट्यूमर पकड़ लिया.
So what I suggest is, when that onco guy is doing the pancreatic stuff, you can do frozen section.
Okay.
And you can confirm your diagnosis.
Right.
And at later date, you can handle your thoracic stuff. So deal two pathologies at two different stuff. That is my point, basically.
Right, sir. Well taken, sir. Thank you, sir.
Perfect. Any other questions, guys? Any more interesting cases? I think we are past 10:30 almost.
Yeah.
Perfect, sir. So we wind up the session today.
Okay, we call it a day then.
Yeah. Thank you, sir. Thank you so much for this topic. So interesting.
Yeah, thank you all for sharing important insights and good participation. Thanks, Joseph, for handling this audio-visual part very well. Thank you.
Thank you, sir.
Thanks.
Okay, sir. Thank you, sir.